dehydration is mucosa, oral mucosa is dry, turgor, slow cap refill, BUN and creatinine. Kidneys will be affected by even moderate dehydration, definitely. Because the kidneys are not getting enough fluid moved to them. They're dehydrated in their whole body. And then this one, the 0.9 can be used for maintenance fluids, right? This can be maintenance, but this is a slow, rehydration. This one, 0.9 and LR can be used for just large volume maintenance fluid if they're ducting by mouth, if they're going for a procedure or something. You have to keep the hydration, keep the blood pressure up, stuff like that. This little sheet, oh no, that's not. This little sheet right here is so good. And then, oh, I think there's a table. Ooh, I'm gonna be down. How many of y'all have the app for this?
The fuck is that?
This is a Facebook. It's for senior, yeah, they're gonna tell you you're not supposed to have that.
No.
Oh, I'm the bad guy, but my students told me last semester, we have the app. Because you can go and it's called Go ATI. Yeah,
Oh.
you get this. This is a and there's
I got 2
a
nutrition books.
little graph in there, and this has all your topics. See, if I was studying for my boards, this is where I'd go. Right there, cut and dry, and maybe a pop-up book. But anyway, does that make sense? Now, the other acute reason is for why that you're using a 0.9 versus the other two. Why would you be giving, and what's that word when you do something very quickly?
Bolus.
Bolus, yeah, a bolus. Like 500 or 1,000 an hour or something, depending on your location, right? Field, they usually put them on a dial plan. We put them on, well, I didn't work in the ambulance, but I know what they do. They put it on prime, so it just drips, it just runs in. ED, we would run it between, I don't know, 500 and 1,000 or something. Up on the units, usually 500 mils an hour, that's all, that's fast. Just to get that vascular volume up without provoking either movement either way. It's perfect. It's perfect for bringing up that blood pressure. That's why you're doing it, right? That's your desired clinical outcome, is blood pressure. So they don't go into, what, MODS? Right here? Hypovolemic shock and MODS. I'm gonna bring this to class every day. I was gonna make you guys a big old poster, because we're gonna talk about this all the time, the shock stuff. And then this one is, again, specific indications like pulmonary, cerebral edema, what am I at here? Cerebral edema and a severe hyponatremia, right? So which one of these do you give for the cerebral edema? Mannitol. Because mannitol will do what? Suck fluid into where? Where does it go?
To the cells.
When you give a hypertonic solution.
Vessels.
Into the vessels, right? Because remember the concentration, the more attractiveness it has, it's gonna suck that fluid in. And it's going to take fluid off the brain is what it's gonna do. Right? So here we're cranking up blood pressure. Here we're trying to get those cells hydrated. Here we are doing a very specific critical intervention, and that's to decrease ICP and also to replenish the sodium in severe hyponatremia. There are other indications of a 3% saline solution, but the one that I indicated is one of the most prevalent things. Let's move along because we still have a lot to cover. So I try to give you everything just right away. Do I want to go into EKGs and electrolytes yet? No, I want to do this first. Yeah, I want to get that out of the way because this is a little bit longer of a thing. There's going to be a test question, and it's going to be colloids. So what you've done so far, tell me what you know. What is a colloid? Large molecular. And what does that mean? What's the relevance of being large molecularly?
It can be dissolved. Volume
That would be a
expansion.
crystal. It's a volume.
Expander.
He's saying it back there. It's a volume expander. And does that fluid stay in the vessel?
Yeah.
Yes. Those proteins are large that they don't seep out of the vessel, they stay in the vessel. That's a good thing, because they, like these hypertonic solutions, will suck fluid in. So your hypertonic crystalloids and your proteins will suck fluid in. The best thing about your colloids is they volume expand, the blood pressure recovers, and guess what? You got an alive patient. Yes, that's awesome. And fluid stays there. Oh, are they at also risk for pulmonary edema? Oh yeah, you see where I'm going? Oh yeah. And maybe brain dehydration, it's a different mechanism there. But, yeah, definitely they could get pulmonary edema, but that's not what, you wanna watch for that, you wanna assess for that too with the proteins, the colloids. But you want to watch for that blood pressure. You have to keep them alive. And then we'll look at the neurologic stuff, does that make sense? Cause they're really going down hemodynamically. So test question, you see what I put here? Blood products, that should be highlighted. You guys are gonna like go, huh? Here in a second, let's start from the bottom. Oh, why did you get platelets? For what? Yeah, she's right. To help so they don't bleed. You're right. So thrombocytopenia, because if you have thrombocytopenia, like in myelosuppression, that's another thing you're gonna know. Low white cells, low red cells, and low platelets, you can bleed. So for thrombocyte, if you have low platelet count, what is the low end on the platelet count? 150. Good job. 150 to 400 or 450 to 1,000. Yeah. So yeah, they're gonna bleed. If you have low platelets, man, you're at risk for having unclotty blood. You have to have, it helps in the clotting and the thickness and the tone of the blood. Good job. Albumin. Now, platelets are alone in themselves, right? We give that for thrombocytopenia. So that is not gonna be a part of this one question. Now, who and why are you giving albumin? Why are you giving albumin? Ooh, she said ascites. And what is that site? What's the initial diagnosis? Severe? Ooh, elderly. Ooh, you guys are thinking now. So for elderly folks, they don't eat protein. They're gonna have a little bit of a lack of serum protein. What do they like to eat? Sugar. Or, you look at their oatmeal like this and then their sugar packets are, because that's all they can taste anymore, right? So they're usually a little hypoalbuminemic, but acutely, who is the person you're giving IV albumin to? Liver failure and ascites, yes. But what is that initial lab called? Hypoalbumin. See how it works? Remember the liver, it's bad. The liver has cirrhosis. It cannot create those serum proteins. So therefore, the one test question I'm gonna have about that one is when you're giving albumin, what kind of pressure are you creating in the vasculature? Oncotic pressure, yes. You guys are getting this. You are actually creating a vascular environment of increased oncotic pressure. And what is that protein again going to do? It's going to stay there and pull fluid into where again? Into the vasculature, into the vessels. And what's going to happen to the blood pressure once you get that extra fluid in there? Remember when they die of hypovolemic shock because they don't have the proteins to hold it in. See, y'all are sitting here, y'all have probably perfect albumin levels. You have total protein, it breaks down to, albumin and, all that stuff, pre-albumin. So you guys are great, because you don't look like you have ascites, your belly's not out to here, right? Because it will seep out. All that fluid will seep out because they don't have enough proteins to suck the fluid into the vessels. And when you lose vascular volume, again, what happens to the blood pressure? It tanks. They die of hypovolemic shock. So, let's see, where were we? Okay, albumin. So that's primarily given, not really for, yeah, I guess really bad, states like TPN, they'll put procalamine in there. They'll put procalamine for like anorexic people. I've seen emaciated, cachectic people that are so emaciated in their bone, they need TPN big time to run 24/7 because it has the bodybuilding protein. Does that make sense? But really, when you're giving albumin, it's usually for your ascites patient. Yeah, and we're monitoring blood pressure. Plasma. Ooh, who are you giving plasma to?
Trauma.
Anybody who has lost a severe amount of vascular volume. What would cause a patient to lose a lot of vascular volume? Keep it simple, because it really is.
Hemorrhage. Bleeding.
Say there's one, yeah, exactly, losses. Keep it simple, really. Yeah, shock is the result, right? So losses, how do you lose fluid out of the body? I do not want to do a practical demonstration. Or, right? Especially loosey-gooseys down here. Watery stools, diarrheal stools. And he said, hemorrhage, right? Hemorrhage. Okay, so hemorrhaging, throwing up too much of this, internal bleeding, you know, which of course is hemorrhage. There's one other big one, you guys. Okay, let's talk about maldistribution of fluid. Traumatic. Okay, working, big explosion.
Oh, burns?
Injury.
Burns?
Burns. Where's that fluid gonna go?
Evaporates.
To it's inflammation. So if you remember inflammation, what
Some shit
happens to
evaporates.
physiology? What happens to fluid? It's called hemostasis. You're gonna have fluid shifting. What about when you, sprain your ankle? Is it gonna swell up? It's inflammation, injury. So this is one of the big things that they might give plasma. Now later on, we're gonna do the rule of nines and the fluid resuscitation with the 0.9. Easy, easy, easy stuff. It sounds like, oh, no, it's really easy. Okay, so plasma is good to replace vascular volume. Is it a colloid? Yes, it is. It's a protein. Is albumin a protein? Is whole blood? There we go. Now we're gonna get into some weird stuff. Now, why are you giving packed red blood cells or whole blood? Blood loss, exactly, hemorrhaging. As evident, how can we measure, quantify measurement of blood loss? Complete blood count, she said, and very specifically, which one? HGH, hematocrit and hemoglobin. What's hematocrit? Percentage of red blood cells compared to all the other components of the serum. Very good. What's hemoglobin? It's the amount of hemoglobin. Okay, so think about it this way. So we got a ratio, which is a gross ratio, which is the hematocrit. That's a percentage. The hemoglobin is what lives on the cell that carries the oxygen molecule. So what we actually look at as an indication of giving blood is the hematocrit, the actual gross blood loss. And they're getting, and I have to tell you, they're getting hyper conservative with giving blood because it's so dangerous and there's a shortage. Always seemingly there's a shortage. So they're allowing the patient to go down to a crit of like 25. Me, old school person, I go, dang, you know, unless they're symptomatic, that's the one word. If they're really super symptomatic at a 28, because what's your low end on a hematocrit? That's right, or 35, or it depends on what ATI. I think there's a lab list in there, right? So below 35 or 37 or whatever ATI says. Yeah, and then, but again, unless they're symptomatic, they will not transfusion. It's just a trend that's happened. Whole blood is given for, donor, like if you have surgery, like elective surgery, you can give your own blood, it's whole blood, which is the best. Autologous blood is the best to get, because you're usually not gonna react against your blood cells, right? But they're both. So why are you giving it for volume? The answer is yes. Yeah, because they're usually hypovolemic, either after hemorrhage or post-surgically. The estimated blood loss may be greater than 500 cc's, so they're probably gonna require, H&H probably gonna end up being low, so we're probably gonna be giving probably 1 unit of half blood cells. But if it is a hemorrhage situation, we're gonna be giving more than that. But this is my point. So it's for oxygen carrying capacity, would you agree? The hemoglobin and the crit, to bring up the crit. But, oh my goodness, you know what nurses forget? This is what they forget, and this is the key thing for safety, so you don't kill your patient. Are blood cells proteins? Big time. Would you then consider them a colloid? Big time. You've got to think of it that way. I don't even know if they teach this in nursing school, but I do, because you could kill somebody with blood. And I'm not talking about the reaction. I'm talking about the colloidal action that will cause pulmonary edema. Now, what if you have a heart failure patient? You don't know if they have heart failure. You can have evidence, like they're in the ED, they're passed out, you don't know. You can get signed, you could do a BNP, for the natriuretic protein for stretching the heart for heart failure, you can do all that stuff. But we don't know, what if they're hemorrhaging? We're not even thinking about that. And then we are cranking the blood. What's that blood gonna do? Is it gonna fill up the volume right away? Yeah, because it's a protein. So this is my point for safety for blood. Not only the reaction, you have to watch that, but you also have to watch for, guess what? Again, fluid overload, hypovolemia, big time. You can, if they have heart failure, you kill them. You can stretch that heart, and now that little myocardium has no inotropic power left. You could literally kill them by that, or pulmonary edema, or both. You see where I'm going? I have a test question. It's going to say, which of these are colloids? Platelets are not, so eliminate that. But are the other ones colloids? What's the answer? Yes, that's right. This plasma is protein, albumin is protein, and red blood cells are protein. Now, platelets are protein, but we're not thinking the same, it doesn't do the same thing. It's like replacement platelet. Does that make sense to everybody? So that's a test question right there. It's going to be which ones of these are colloids. It's that simple. And platelets are not considered a colloid, right? They are considered, we give them for clotting, don't we? We also, speaking of clotting, the other reason we give plasma, it's not only because it's a volume expander, because it contains, guess what? Clotting factors. So does it help with that hemorrhage? Big time, yes. There's another one that we give specifically and sort of isolatingly for clotting factors. Does anybody know what it is? Cryoprecipitate. Very good. So they might be getting some, if they're having problems with bleeding, like guess what, alcohol people. God, I can't wait to get into that liver lecture. It's so much fun. They bleed because they don't have clotting factor. They bleed from every orifice you can think of. You look at them and their eyes will bleed. Not really, but it's almost that bad. So that's another test question. Test question, where does the fluid move? Test question, where does the fluid move? Test question, where does the fluid move? And what are the side effects of giving a hypertonic solution? That's 4 questions right there. And colloid, remember what's the big P word that's associated with colloids? Proteins. Let's all say it. 3, 2, 1. Protein. Yes, and that's going to be colloids. Sometimes when you say it, it really goes in, right? Okay, good. What are the side effects of giving a hypertonic solution that could kill them?
edema,
pulmonary edema and,
fluid overload,
well, fluid overload leading to pulmonary and brain.
dehydration,
Yeah, remember the big O hangover, yes.
brain
Part
dehydration,
of the
pulmonary
symptoms of a hangover is because of brain dehydration. And the brain does not like being dehydrated. Just wait till we get into DKA and HHS. Okay, let's go into electrolytes. Now, remember at the beginning of the class, did I say I'm generalizing this? So you get the big stuff. Sodium with that N is going to equal what organ, mostly? Neuro. Good, good. You guys are amazing. Calcium, what does that primarily affect?
muscle,
Muscle. Now watch this. I'm gonna do a striatic muscle, triangle muscle like I don't know, bicep or quad or whatever, you know? But guess what? And a lot of people forget this. What is the strongest muscle in the body?
heart,
The heart. The second strongest muscle is probably the erector spinae that keeps you standing up. And boy, when you have a spasm in the erector spinae, you can't breathe. I've seen back patients like that. They literally cannot breathe because it's a very, very strong muscle, bands, you know. But yeah, the heart, look at this. We have a couple heart things. And you guys have already eliminated the heart for K. But before I move on, also think calcium and heart. Why do we give calcium channel blockers when they're going into AFib with RVR? To slow down the atrial rate and the ventricular rate. Oh, and by the way, I'd like to get into a little bit of the ACLS today. What time do we, oh yeah, we have time, sorry. Okay, so we have muscle calcium. Now, what if you have hypocalcemia? What could that cause if you have hypocalcemia? Yes, that technique. And what's technique? Spasm. Technique is actually, when you talk about tetanic muscles, it's like it's in a tetanic spasm. Are spasms good? What happens to a sustained tetanic spasm? Rhabdo, breakdown of muscle. Is that good for the? No. We're gonna get into malignant hyperthermia later on. But if you go into a tetanic spasm, you can break down muscle. That could go to the kidneys, shut kidneys down. Too much protein breakdown. But the heart, woo! Can calcium slow the pulse rate down? Some conductivity? Yeah, they say that, yeah. It actually slows it down. It can bring down, so AFib, is AFib fast or slow? Tachyarrhythm, rhythm.
fast,
It's
fast.
definitely, it's like VFib, tachy, AFib, tacky, except littler fibrillation waves, You know, the evidence that it's a smaller organ is on the EKG, versus, VTAC and VFib is like big coarse waves. Anyway, we want to slow that down so the patient can not go into shock, right? Okay, we all try to tie it in. So this is mostly muscle. Oh, what are the signs that you checked for hypocalcemia? Yeah, exactly, Chostek. So which one is the Chostek? The tap, very good, the tapping. And they do almost like a, what's it called? What's that thing called, that disease? Oh, yeah, it's almost like a Tourette tick. Tourette's is just the saddest, most fascinating thing, but yeah. People with Tourette's, they do all kinds of weird ticks, and of course they have the verbal ticks too, which is very insulting. I don't know if you've ever watched it, it's just amazing. Anyway, they go like that. And what's the other one? The Trousseau's. And how are you gonna test for Trousseau's? And that carpal spasm. You do, that's exactly what you do, is you put a blood pressure cuff on there and it just goes, and that's exactly what it looks like, right? And that's with hypocalcemia. Hypercalcemia, so again, I have to tell you this. I don't have time to cover all of the effects for your CNS, so please put that as your notes to start studying it now. Even if you have to make flashcards, What does hypocalcemia do? I'm just illuminating the big, prevalent, important things. Now, Kay, we know heart. There's one other thing I want you to write down. It is called generalized weakness, muscular weakness. Primarily because when you have an imbalance of sodium and potassium, it affects sodium-potassium. What do you need the sodium and potassium for? Muscular action. So if you have especially hypokalemia, it's generalized weakness. I mean from here all the way down. Elderly people tend to get the generalized weakness. That's our admitting ER diagnosis, generalized weakness. And then what do I do? What do we do? We go to the computer, guess what you're looking at? How's their K level? See where you're going? Because it looks like a diagnosis. We got our diagnosis. Let's confirm it. Let's get a differential by our quantifiable data. You know, even as a nurse, we do that. When you become a nurse practitioner, you have to do that, right? So I'm looking at my K level, I'm like, oh shoot, they're severely hyponatremic, or kalemic rather. And so that explains why their muscles, why they went like this or walking along and then they just go like this. Does that make sense? You know, their muscles just give out. So put generalized weakness is the other prevalent one. So, and arrhythmias, you already know that. That's taught number 1 in nursing school. So, now we can get into a little bit of our rhythms, which we're going to do tomorrow. Oh my God, I can't wait. These are not normal, are they? What is that right there? That should be the T wave. What's the problem with it? It's too high. What do they call that? Hyperacute T wave or peaked T wave. Very good. Peaked T wave. Caused by what? This is a test question. Hyperkalemia. Don't you like that? Sometimes, you know, nature just is so easy to figure out. Because hyperkalemia equates to a hyperacute T wave. That is a test question in, I think AH2. So I'm already giving you the test answers there. Now, what if you have a depressed or an inverted T wave? Hypokalemia. Oh yeah. And then there's another thing that you're going to get an inverted T wave from out of that is going to be ischemia. So a non-STEMI, we'll talk about that tomorrow. So a non-STEMI like myocardial ischemia can cause also a depressed T wave or inverted T wave. You guys are going to know this stuff like the back of your hand. I promise you're going to do it. Okay, magnesium. God. There's a relationship between calcium and magnesium. And this is where it gets really hairy. But what is the unique thing about MAD? Deep tendon reflexes. DTRs. So it's not killer, but it's a good for differential diagnosing with hypomagnesemia. Plus, also, hypomagnesemia can cause what? Actual fatal cardiac arrhythmia. Torsades de Point. Oh my God, you guys are good. So let's go to the heart here with this particular thing. So this is what torsades looks like. Big, 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 and then little. Sometimes it goes beyond or below the isometric line. You know, sometimes it'll do that. Very different from VTED. Those are the two arrhythmias that are really hard to distinguish, and I'll talk more about tomorrow. But severe hypomagnesemia can cause torsades de Point. Hence, what is the treatment for torsades de Point?
Magnesium.
Magnesium IV. Good job. And then the DTRs. And DTRs are easy to memorize. Just think if it's hypermagnesemia, they're going to have hypo-DTRs. If it's hypomagnesemia, they're going to have hyper-DTRs. So it's just opposite. Hypo, hyper, hyper, hypo. Yeah. So you guys, I have to tell you, in the setting, as a nurse practitioner, you will do this. We don't use the hammer very much, but it's a good finding. It's a good, like, you know, your findings, clinical findings. So when you do like this, and they're hypermagnesic, you're going to get very little reaction. But then you have to think, oh crap, this is hypermagnesemia. Please look up what hypermagnesemia causes. And then if you have hypomagnesemia, what's gonna happen? Hyper DTRs, right? So it's just like this. FOS, look at FOS. And then if there's any test question that I'm gonna give you for FOS, I will let you know. What do I wanna do next? Okay, so what are your colloids? What are your big colloids that are gonna be on your test? Albumin, plasma, which is FFP, correct, very good. Whole blood, red blood cells, so we have there's one missing. So albumin, plasma, and red blood cells, is that it? I'm missing something. Oh, I know what it is, It's head starch. Write this down. Did I put this on here? I don't think I did. Oh, it is on here. Oh, yeah, here it is. So, FFP, see right there? You just have to read it right. FFP, the crown precipitate is mostly for what? What's the crown precipitate for? And the C equals clotting factors. But I'm not gonna have that be the answer. So what are they gonna be on your test? Fresh frozen plasma, albumin, blood cells, red blood cells, and head starch. Head starch is made in the lab. Okay, so let's go again. What are the 4 volume expanders? Colloids. Whole blood, good. Albumin, good. Head starch, and that's an answer to a test question. Okay, let's go into, we did the inodrome, let's get into some ACLS drugs. I'm basically giving you your test. Oh, what time do we have? I just remembered something I need to plant today. Are you guys ready to tackle a little bit of adrenergics? We have to do it. We really do. Because guess what, on your first test, you're gonna have about 4 or 5 questions. Can I answer those questions right now? Yeah, I'm going to. At the beginning of the class, I stated 4 different types of adrenergic receptors. Right? Oh, I said that to you, didn't I? I sure as the heck did. Let's see who read the actual document. Okay, what are your different receptors? A1, A2, U1, U2. Was that hard? No. See how easy it is? Okay, we're gonna make this so easy for you guys. You're gonna get these right on your test. You will. If you study it. Do you have to study it?
Yes.
The answer is yeah. You can't just get it from me because this lecture goes like, bam, 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 like, what? You know, it's really fast, right? But you gotta study it. You gotta make some flashcards or however you study best. Okay, now this is gonna be A1. We're gonna go with the stimulation, and then we're gonna go with the blocker. Does that make sense? Because we give stimulators, we give blockers. What is the big quintessential blocker? Beta blocker. It's in the name, right? So that should come to mind. How about alpha blockers? Okay, I'm planting seeds, This will all come together. I promise you, this will come together for you. So sometimes we're stimulating those adrenergic receptors throughout the body, and they live all over the body. Hey, they can live on vessels way down there. They can live on tubes like the urethra. You see where I'm going? They can live like the bees. They can live on SA nodes, or they can live in lungs. So adrenergic receptors are all over the body. But you have to know what drugs stimulate and what block. Are you guys ready for this? Because these are going to be on your test. Let's start with alpha 1 stimulant. I'll do it this way. Yeah, that's how we're, because usually you get side by side. If I stimulate an A1 receptor, we're gonna talk vascular and, urinary, like the urethra. If I stimulate A1 receptors throughout the body, what is that gonna provoke? Yes, vasoconstriction, good. So you're gonna get not only vasoconstriction, you're gonna get constriction of your urethra and other tubes in the body. So think tubes, think plumbing is gonna constrict. So keep it easy. This actually is really easy. Now, so we're stimulating up here on all these, and we're gonna be blocking here. Does that make sense? Now, when you give an alpha 1 blocker, what's it gonna do? Dilation. It's opposite. How easy is that? So you're gonna dilate vessels. Vessels and urethra. Right? So dilate and or constrict vessels in urethra. Now let's get into some meds that are gonna be on your test. Okay. Which drugs, just in general, one word, and this is gonna be a part of your psyche. When you're done with this class and med-surg, it'll be a part of your psyche, and you can teach this stuff. So, why on earth would you give an alpha 1 stimulator? What does it do when you stimulate A1 receptor? It constricts. So under what conditions will you give an A1 stimulator? Shock. Like, you might have to give it for hypovolemic shock. You give the fluids first. What's the overall word that you're going to talk about next week that you give these A1 stimulators? What's the one word? Starts with a V. Vasopressors. What are your vasopressors? Are they like adrenaline? What does adrenaline do in your body, to your vessels? Vasoconstrict, right? So what are our vasopressors? First of all, what lives in your adrenal glands? They're called catecholamines, by the way. So what are they? Dopamine? Norepinephrine and? Epinephrine. Good. Epi, norepi, and dopa. Ooh. Those are 3 endogenous that we have for fight or flight that causes us to constrict, get to the muscles so you can run or fight, right? Same thing here. But in the case of a person who is going, they have hypovolemic shock, or they have systemic inflammatory, like in sepsis, vasodilation, you need a constrictor. Now, what's that constrictor going to do? Increase the blood pressure, so you then get an increase in cardiac output, and then it decreases the hypoperfusive state that they're in, and it prevents shock and mods. See where we're going? Yeah. And what about an alpha 1 stimulator? How about epi for symptomatic bradycardia? What's the problem with bradycardia?